Welcome to the deep dive. Today we're digging into something really fundamental in diagnostics, telling pleural effusions and pneumothoraxes apart on imaging.
Yeah.
We're using some fantastic details from Chapter 1, Episode 3 to guide us through the visual clues.
It's all about reading those images.
Exactly. Think about it. You're faced with a patient, short of breath. Is it fluid? Is it air? Getting that right fast is critical.
Absolutely. And what's fascinating, I think, is how these sometimes subtle visual cues on the scans give us so much information. It guides the diagnosis, the treatment, everything.
Connecting the dots between what's actually in the pleural space, fluid or air, and what we physically see on the scan.
Precisely. Those visual cues are just vital.
Okay, let's kick off with pleural effusion. So simple definition. Fluid where it shouldn't be in that pleural space.
Yep.
But the immediate question is, how much fluid are we talking about?
Mm-hmm.
And, can we actually see small amounts? This is where radiology gets really interesting.
It really does. And yes, even tiny amounts leave clues on an X-ray, a CXR. Yep. The most sensitive view, actually, for small amounts is the lateral decubitus. You lie the patient on their side.
Right.
That can pick up as little as, believe it or not, 10 milliliters of fluid.
Wow. Just 10 milliliters. That's tiny.
It is, long before you'd see it on a standard upright film. Now, if you have a bit more, maybe around 50 milliliters, you might start seeing some blunting of the posterior costophrenic angle on a lateral view.
Okay, the back angle first.
Then, when you get to the point where you see blunting of the lateral costophrenic angles on a standard PA view, well, you're probably looking at somewhere between 200 and 500 milliliters.
That's quite a range, but it gives you a ballpark figure just from that angle blunting.
Exactly. And for larger effusions, you get that classic homogeneous opacity wiping out the angle in the diaphragm outline with that upward curving meniscus shape.
Right, higher on the sides.
Concave towards the lung, yeah.
Okay, so that's upright. But what if the patient has to lie flat, supine? Does it look totally different?
Oh, absolutely. Gravity plays a huge role. Supine, the fluid layers out posteriorly.
Spreads out.
Yeah, so instead of a sharp meniscus, you often get this sort of generalized veil-like haze over the lung field.
Like a subtle fog.
Kind of. But critically, you usually don't see that meniscus, and you can often still see the lung's blood vessels through the haze. That's important.
Okay, so preserved vessels, no meniscus, just haziness. Got it. What about other imaging? Ultrasound, CT.
Well, ultrasound US is great. It's bedside, it's dynamic. Fluid usually looks echo-free, black. And you get this bright white line, very echogenic, where the fluid meets the compressed lung. If it's a complex fluid, like an exudate or pus, you might see strands, septations, or echoes within it, plus pleural thickening.
And CT, what does that add?
CT gives you amazing detail. The fluid itself shows up as this dependent, low-density, often kind of sickle-shaped collection.
Sickle-shaped, okay.
But CT's real power is looking at the pleura itself and the underlying lung. Is the thickening smooth and uniform, suggesting something benign? Or is it nodular, worrying for malignancy?
So it characterizes the fluid and its surroundings.
Exactly. It can clearly show if fluid is free-flowing or trapped in pockets, loculated. One thing it can't reliably do, though, is tell you if it's a transudate or an exudate just based on density.
Right, that composition question still needs other clues. You mentioned angles earlier, too.
Yes. A key point on CT. Pleural-based lesions or fluid collections tend to make an obtuse angle with the chest wall. Wide angle. Lung lesions usually make an acute angle. Sharp angle. Helps tell if it's inside or outside the lung.
Obtuse for pleural, acute for lung. Nice tip. And specific causes, left versus right side.
Yeah, there are some classic associations. Right-sided effusions often make you think of things like ascites, heart failure, maybe a liver abscess.
Okay.
Left-sided, think pancreatitis, pericardial disease, even esophageal rupture.
Yeah.
Bilateral effusions often suggest a transudate, like in heart failure or kidney disease. And really massive effusions, you have to worry about malignancy.
That's incredibly useful context. Okay, let's switch gears from fluid to air.
The opposite problem.
Exactly. Air in the pleural space, a pneumothorax. What's the visual signature we're hunting for there?
Air looks, well, blacker than lung on X-ray, right? More radiolucent. The key sign is seeing the visceral pleural line, the edge of the lung itself separated from the chest wall.
A distinct line.
A thin white line. And critically, in the space between that line and the chest wall, there should be no lung markings, no vessel lines, just blackness. Usually seen best up at the apex in an upright film.
No vessels beyond the line. That's the giveaway.
That's the key. Sometimes an expiratory film helps make it pop out more, but watch out for mimics.
Ah, piffles. Like what?
Skin folds. Especially in babies or older folks with loose skin, they can look like a pleural line.
Tricky. How do you tell them apart?
Well, a skin fold line might extend beyond the ribs, or you might still see lung markings lateral to it. A real pleural line stops at the edge of the lung, and there's nothing but air outside it.
Got it. Okay, and again, what about the supine patient? Air rises, so where does it go?
Yeah, this is often missed. Supine, air collects anteriorly, sort of under the chest wall at the front, often near the base or midline. You might not see that classic apical line edge.
So what do you look for?
Subtle signs. Maybe one lung looks generally blacker, more transradiant, or look for the deep sulcus sign.
Deep sulcus.
Yeah, the costophrenic sulcus where the diaphragm meets the ribs laterally looks unusually deep and dark because air is trapped down there.
Ah, like a deep V shape.
Exactly. You might also see air outlining the heart border or diaphragm unusually clearly, or even the double diaphragm sign where you can see the bottom of the heart outlined by air.
These are subtle but specific signs then.
Very specific if you know to look for them.
And the emergency tension pneumothorax.
That's a clinical emergency first, imaging second. But on CXR, you'll see the lung totally collapsed, often shifted mediastinum. The heart and trachea pushed away from the side with the air, and the diaphragm might be flattened or even pushed down.
But the key is clinical suspicion. Don't wait for the x-ray if you suspect it.
Absolutely not. Treat first. The X-ray confirms later.
So, wrapping this up, what's the big takeaway for you, the listener, the clinician? We've gone from subtle blunting for fluid to that sharp pleural line or a deep sulcus for air. These aren't just abstract findings. They're a visual language.
Right.
They let you quickly diagnose conditions that need immediate action. It's about mastering that language.
It really is. And it makes you wonder, doesn't it? In this age of, ever more advanced tech and AI coming in, how crucial do these fundamental visual skills remain? Spotting that line, that haze, that subtle shift?
That ability to decode the image directly.
Yeah. How much does that skill continue to shape rapid, effective patient care right at the bedside? It feels, well, indispensable. Still absolutely critical.